Okay, so I want to welcome everyone to our May Provider Forum. We are honored to have Ronni Blumenthal with us. She is the President CEO of the Phelan-McDermid Syndrome Foundation, and she is going to discuss this diagnosis, and I'll go ahead and turn it over to her. I will be monitoring the chat, and I'll handle the presentation when you are ready, Ronni.
Thank you. I'll just briefly introduce myself, and maybe you could go around and each tell me where you're from, and then we can start the presentation. So
Okay,
as you heard,
about 88 people on right now.
Excuse me?
We have 88 people on, so it might be hard to.
Oh my goodness. Okay. That's not what my screen is showing at all. I have gallery view with just a few for some reason. Okay. Well, we won't do that then. I'll just introduce myself. So I'm Ronni. I'm located in Sarasota, Florida. I'm originally from upstate New York, which is where I started my career along the Hudson Valley. I worked in autism services. Anyway, I've been with the Phelan-McDermid Syndrome Foundation since 2018. I did not know that the organization actually was founded here in Sarasota. That was kind of coincidental when I took over, because obviously it's a rare disease. As most of you know, it's one of the 6 conditions that are kind of give you a little jump start or a little head start on the waiver, which is, I guess, why we're here today. And so some of you may be serving people with Phelan-McDermid syndrome. Looks like audio is still an issue for some.
Which?
Can everyone hear? Can some of you hear me, I hope?
No, I think it's people are muted, so they can't speak, but they should be able to hear. So
yes,
we
can.
Okay.
They check in on their end.
Okay, seems like a bit of a mix. Anyway, so we serve 105 families as of this morning anyway, here in Florida. Our membership is growing literally by the day as genetic testing, which is the only way to confirm diagnosis, becomes more available. Our total membership is about 3,600 worldwide. But the incidence for the condition is about 1 to 2% of all autism diagnoses. So for me, it was very interesting when I started 7 years ago and I started reflecting back on my career, mostly working with people who had autism. I realized there were quite a few who probably had Phelan-McDermid syndrome once I understood better some of the various parts of the condition. So if you want to start the presentation, we can.
Yes, I'm going to.
And I'm sorry, I've asked Dina to do this for me because for reasons I don't fully understand, my internet does not like to screen share.
Okay, hang on 1 second. Okay, so there we go. Everyone should be able to see. And then you just let me know when you want to switch to the next one.
Yep, we can already move to the next one, actually. That's just sort of a cover photo with our address. And if you see on the bottom there, it said info@pmsf.org. So if after the presentation, you need to reach out on behalf of somebody that you're serving, that would be the best way to do it. I'll give you my email at the very end. So Phelan-McDermid syndrome is treatable and curable. That is our vision for the future. Our mission is to make today better and the future brighter for everyone living with Phelan-McDermid syndrome, from the moment of diagnosis to the delivery of treatment and cures. We can go to the next slide. And the next slide. So without getting into a genetics lesson, Phelan-McDermid basically also has been called 22q deletion syndrome, and it's very rare. It's a genetic condition that's caused either by a deletion at the end of the 22nd chromosome or a variant to, or a mutation is kind of the old language. We prefer variant, where there's been a switch. So it's almost like a misspelling in a word or a tiny piece that's been moved to the front of the sentence that should be at the end of the sentence. So all of that can cause varying degrees of Phelan-McDermid syndrome. The primary gene is the SHANK3 gene, which has been identified as an autism-causing gene. We can go to the next slide. So basically, like most of the neurodevelopmental disorders and the folks that you work with or your staff work with each day, there's altered brain development. We see typical early regression that is somewhat familiar to those of you who maybe work with children who have autism. It can affect all of the body systems. We have pretty extensive clinical consensus guidelines. So there's the typical learning and communicating, eating and sleeping, which are also in GI issues, which are also kind of popular with autism. But we also see about 30% of our population with seizures. Some of them are intractable, so they have a Lennox-Gastaut syndrome diagnosis as well as Phelan-McDermid syndrome. But basically what you would see is hypotonia, low muscle tone, which affects every part of the body from GI motility to the ability to ambulate, some challenges learning, and then often there's early speech that's, again, typical of autism, later lost. Some of our folks use augmentative communication devices or PECs or other communication systems, but very few, other than those who have very small variants, are able to speak out loud. We can go to the next slide. Okay, so this gives you a little bit of an idea. Again, we just went through some of this, and all of this is available on our website. If the QR code there, if you know that you're serving someone with Phelan-McDermid syndrome, it would be great to click on that and save that. That will give you the clinical care guidelines, which basically break down each body system and kind of give you a roadmap for proactive testing that you can do, treatment possibilities, and things to look out for. Some of the things that are here, I think, are known to all of you. So we have people who use wheelchairs. We have kids and adults who use AFOs, who may use a walking device, and quite a few who walk independently. And I think we've pretty much covered the other things on here. If you go under health, actually on the top left, you can see again that it can affect every system of the body. Next slide, please. So some of the things that are kind of unique that I wanted to go over today. So one, altered responses to pain. So this is really important, I think, as a residential provider, because the kids and adults don't express pain like you and I do. So we've had situations where, we've taken someone for a dental and found out their back teeth were shattered from grinding, or had been worn down from GERD, and we had no idea they were experiencing any kind of, upper GI pain. We've had people who were limping slightly, and a good caregiver noticed a slight difference in the gait, and then that turned out to be a broken bone. So it's really important to be tuned into how the person typically moves through the environment, and to look for any subtle changes, because it could be indicative of something more serious. Most of you are probably familiar with autism. I don't think I have to spend a lot of time there. We do see some pretty significant changes in adolescence, sometimes with the onset of menses in the girls, and around puberty or early adolescence in the boys. This is kind of an unfolding picture, because as of a few years ago, our average age was 9, and now our kids are heading into the teen years. And what we are realizing is that a large number of our folks have some kind of neuropsychiatric involvement when they reach adolescence. How would you know that? You would see maybe a significant behavior change, such as aggression or other challenging behavior. You might see the opposite. You might see total withdrawal. You might see a loss of very basic skills, difficulty communicating if they can speak. Maybe they'll forget how to eat. There's somebody who ate independently, used utensils on their own, and they sit at the table and they seem completely bewildered. So catatonia is one of the most typical ways that the neuropsychiatric challenges manifest, but we've also seen psychosis, bipolar disorder, etc. The good news is we have an excellent team, international team of top psychiatrists and neurologists who have put together some great care guidelines. We have a lot of information, and we're able to consult with treating psychiatrists and give that body, that group of physicians will meet for free with any psychiatrist, neurologist, or treating physician to kind of walk them through the protocols that work. The reason that's really important is, unlike some of the other folks you may work with who have challenging behavior, antipsychotics can actually exacerbate what's going on rather than help. So oddly, and residential providers don't like this, and I understand why, because I was one myself once upon a time, The best intervention for many of our folks is extremely high doses of Ativan, like off-label use, large doses. Over time, they come down a little bit, but that is the quickest way to bring somebody out of catatonia. Again, this is all available on our website. The consultative group is free. And so if you have someone, again, that you're caring for and you see some sudden changes, neuropsychiatric is what should come to the front of your mind. Because of the hypotonia, very often we see choking and aspiration. So there's a little bit of risk there. Some of our folks are on thickened liquids. Others eat typically. Many use G or GJ tubes for feeding as well to avoid the choking and aspiration. We see quite a bit of aspiration pneumonia. Difficulties with sleep, which I think is really like across the whole autism spectrum. So that's probably not so new to anybody. And similarly with GI disorders. I think for our group, motility, because of the hypotonia, the low muscle tone, food just doesn't move through the system. So the constipation or the issues that we see usually link back to motility. So a motility specialist is very often a part of the care team. So again, that hypotonia, both internal and external manifestations, right? Being floppy, not being able to hold themselves up, not having the ability to hold their head up, perhaps, or to use, have precise fine motor skills. Kidney abnormalities also are fairly common, meaning they may not have, they may be born with one kidney or they may have some other issues. Lymphedema really only affects about 15% of our folks, but that 15% that has lymphedema does require PT treatment. We went over neuropsychiatric illness already and seizures. Temperature dysregulation, probably important for Florida. For years, we held our biennial conference in Orlando until we realized there was a reason everybody was passing out. And that's because the kids and adults don't sweat. They don't regulate, their body temperature doesn't regulate yet like yours and mine. So hot weather is extremely dangerous and they need to make sure that they're hydrated and have a hat and just that you check in, every now and then. It can come on very quickly. And then also we see some visual issues as well. Next slide. So again, I think I said this at the very beginning, we're underdiagnosed. There was a paper that came out that estimated prevalence to be 1 to 2% of autism diagnoses, which is a huge number, right? So you have to kind of wonder why we only have 3,500 plus. There's a number of reasons for that, and it's been really interesting for me over the past 7 years to watch that unfold. Again, because genetic testing is becoming a little more available, which is wonderful. But we're now starting to see more diversity in our population. So when I first started, I went to my first conference and I asked if there was some kind of relationship between the genetic condition and a specific group of people. I'm going to unmute myself. I hope that was okay. Anyway, whoops. Okay, we were a little further ahead. There we go. I think we were sitting here. Okay, we can actually go on to the next slide. I sort of lost there we go. So as I said earlier, we're getting about 1 new family per day. The reason that we're seeing more diverse population is because genetic testing, now that it's more affordable, is reaching communities that are typically underserved or may not have access to things like expensive genetic testing. And so as that's happening, our scope is widening internationally and here in the United States. And we expect that trend to continue. So you can get a quick look here. We've been around for 22 years, but the data goes back to 2011. There were only 206 identified people. And now we're, well, that's actually a slightly dated number. So we're over 3,600 at this point. We can go to the next slide. As you can see, the US is where most of the affected families are. That dark green, if you look at the key, is 1,000, at least 1,000 people, and that is unique to us. You can see some of the other areas have, I'm going to probably change the way that this is done because it's too wide a span, but we have pretty strong partners in Australia, in the UK, in Canada. We have partner organizations in France, Italy, Brazil, Peru, Mexico. And then we have little kind of clusters, I guess I call them, which is just areas where it's really hard to actually form a 501c3 or an equivalent to that. So groups get together informally and they have a leader and then they interact with us. And we are the basic keeper of resources on an international global level. So all of our materials, we try to translate as many of them as possible. We have a genetic registry that right now is available in French, Spanish, and English. And we'll be adding more languages to that. So you can see overall, though, the breakdown between the US and international is almost like half and half. I should also mention this is very rarely an inherited condition. It's considered de novo, meaning it's just a random thing that happens at birth. There is a small subset of people who have a translocation, a misplaced part of the gene, and that can be inherited, but that's quickly visible on a genetic report. We offer genetic counseling through Mount Sinai Seaver Center in New York to our new family. So when they come in, they learn about that. If there is a translocation, which again is quite rare, then we refer them for family testing in case their siblings or others who would like to know if they're potential carriers. We can go to the next slide. So these are the three areas that the foundation focuses on, and any of the information or resources are available to you, to your staff, to the families that you work with. In fact, if you have families and you do know or are supporting somebody with Phelan-McDermid syndrome, I'd love for you to ask if they're members of the foundation, and if not, hook them up. We are kind of the numbers keeper for on an international level, and that really helps us drive our research, because the more people that are identified, the more likely pharmaceutical companies are to be interested in us. We can talk a little bit about that in a minute, but that's really important for the future. So we do Connect, which is family support. We offer online support groups. Some of those are just general for people who are just trying to cope with having a child that's not neurotypical. We also have a bereavement group because we have lost some children to, not specifically to Phelan-McDermid syndrome, but to some of the other conditions that can come along with it. We also, as I said, have access to a psychiatrist, genetic counselor, a medical advisory, and scientific advisory committee as well. Improving medical care, we're trying to build up as much as possible. Again, that neuropsychiatric support, we're training doctors as we go, psychiatrists, in how to treat this as they move forward. And then in Cure, we work very closely with from bench to bedside. So we're working with translational science, which is in the laboratory, where people are identifying potential molecules or gene therapy that could potentially change the future for these young adults and children. And then also ultimately for a cure. We can go to the next slide. Okay, so again, PMSF, that's our YouTube channel. These are just a couple of topics that are available there. So if you or your staff, again, are supporting somebody and you'd like to do a deeper dive into some of the major areas, then please go to our channel, and that's some of the information that you would be able to access there. It's more than that. These are just a couple that we chose to highlight for the slide. And the next. Okay, I talk quickly, so we'll have plenty of time for Q&A. So that was the end of the presentation. I did send Tina a handout. One of our staff, actually, her child is about to enter an intermediate care facility in Iowa, and she put together a packet. So we de-identified it so that you could all see what it looks like, because it just kind of gives you all the individual information. It's really beautifully done. As a provider, I would love if everybody came through the door with that level of information, both personal and general, right? Because it's super helpful getting somebody settled. So that'll be available to you. I did see someone asked for the presentation, and I think that's fine to send out with that as well.
Right, so we will send out a copy of the presentation afterwards. We're also going to place this on our YouTube channel for people to reference. So right now we could go ahead and open it up for questions. You can either put them in the chat or unmute yourself and ask, because I know this is a rare condition that most people are not familiar with.
Yeah, I'm curious if anyone is supporting somebody at their agency with Phelan-McDermid. So we definitely have people living in congregate settings in Florida. I'm just not sure how many of them are with the ARC.
Right.
I got a question. This is
Sure.
Alan Abramowitz from the ARC of Florida. How do they decide to genetically test you? Because it seems like the issue, there may be a lot more, especially in the countries that have nobody, that when do they decide, like in the Florida, to test someone for that?
So it's a little bit random. So as you may know, so for early testing, like if a child is in the NICU, they may do full testing, but actually the conditions that are tested for at birth, to get on that list, you have to have a treatment available. And since we have no treatment at present, we are not on that screening. So basically it's a doctor who sees autism and the hypotonia, and there are some physical stigmata. It's not like Down syndrome where it's something very specific, but some of our kids have like funky toenails, very long arms, very, very long fingers. Their ears can stick out a little bit. So I guess it's really a doctor who has curiosity and wants to dive in. I think it's becoming more typical now when there's an autism diagnosis to do genetic testing. We're part of a coalition that has over 30 rare conditions that manifest as autism. So that's really a standard actually that we push for, that if you have someone with autism, genetic testing is a smart thing to do. We also have an influx later, as I said at the very beginning, around adolescence, we have when the neuropsychiatric symptoms show up, very often that psychiatrist or neurologist will order genetic testing just because they see this dramatic change and they're just trying to figure out, exactly what's going on.
Okay, so we do have some questions in the chat. One is, what type of training does the foundation provide to general providers?
We haven't been asked to do a whole lot of training, but we would be happy to work with somebody. If you have someone, or more than one person in your area and you would like for us to do some virtual staff training, we'd be happy to do that. You just let us know what it is that you're looking for.
Okay, and is this condition classified under autism?
Yes and no. It's not 100%. Not everybody who has Phelan-McDermid syndrome has autism. The vast majority do. So 80% of our population has an autism diagnosis. But to be perfectly frank, sometimes I think families push for that diagnosis because, as you all probably know, for the smaller, younger kids, to get ABA, you need an autism diagnosis. And that's one of the ways that we get early intervention services. So there's a little bit of a push. I personally have not seen what you would expect to see in like classical autism in this population. They're pretty social and very affectionate with families and with others, but they do have a lot of the stereotypical behaviors, self-stimulation, other things that you would look at and your bells would go off around autism.
So does insurance or Medicaid pay for genetic testing?
I'm not sure about Medicaid in Florida, but private, yes. I'm going to say Medicaid. No, I shouldn't even guess. I really don't know. I could find out and get back to Dina.
Do you all have a legislative agenda beyond more services for the Medicaid waiver and getting people off the wait list? Is there any legislative agenda unique to this disease?
Unique to the disease? No. As I mentioned earlier, like we're in a rare epilepsy coalition because about 30% of our kids are pretty drastically affected by seizures. We're in a group for neurodevelopmental disorders that have a genetic link to autism. So we hitch our advocacy wagon onto those, but nothing unique for Phelan-McDermid syndrome. Frankly, with 3,600 people, like nobody is really listening. So for us, the autism and epilepsy communities are the best way for us to advocate and be heard.
Okay, so one question is, can you explain more about catatonia and the common presentation?
And the what presentation?
Common presentation.
Okay, so it can depend. There's different levels of catatonia, and I'm neither a neurologist or a psychiatrist, so I'm going to put that out as a disclaimer. But basically, again, what we'll see is maybe somebody who gets stuck. may literally wind up in a corner staring at a wall, not particularly responsive. We've had someone with really classic catatonia, probably what you think of in your head when you hear the word, where they literally are frozen, cannot move, and they need to be brought to the hospital immediately. And then we work to bring them back out of the catatonia again. It can manifest as a skill loss, confusion, stopping, disinterest in things that were formerly pleasurable, just kind of like a flattening across the board of varying degrees.
Okay, let me see. I'm scanning through.
I would assume this is an orphan classification. That's why there's no research going on, because it's so low.
No, actually, we have a ton of research. So because SHANK3 is a pretty well identified autism gene, we actually have a great body of literature. We're one of the older groups. We've been around now. This is our 22nd year. So even though the cohort was very small, and when they first met, I think it was 1998, before they even formed a foundation, there wasn't much going on. But we actually are about to start a phase 3 clinical trial for an oral medication. That was our phase 2 was very successful. And then we also are, within this calendar year, we should be starting a phase 1, meaning checking safety and tolerability for actual gene therapy, which is super exciting for us. So a little scary. And that's why we like to kind of involve all the different types of pharmacological approaches, because it's not one and done for everybody. So gene therapy, in this particular case, a healthy gene is introduced with a non-disease bearing virus. But the way that they get it in is an injection directly into the brain. So they have to go through the skull and then into the brain. Not every family is going to want to do that. The phase 1 trial is very, very small and limited to adults. Which is another thing, you want to be careful, right? When you're working with pediatrics, you have to be careful with clinical trials because you don't want to hurt children. But at the flip side, sometimes we know like gene therapy will be more effective the younger that the child is. So we're hoping for successful results in the adult population in the gene therapy trials, and then maybe getting permission to launch phase 2 or 3 in pediatrics. But we actually have people working in a variety of different areas for treatments or cures.
Okay, so one question in the chat. An individual has a sister with autism and CP and a number of the symptoms of PMS. Would it be wise to have her tested?
I don't think there's any harm. I mean, it might not turn out to be Phelan-McDermid syndrome, but again, there's a lot of other rare conditions similar to ours, and each one has some nuance to it. And it also offers, if there's a family involved, it offers a community, which is, I think, priceless. A lot of our families feel super isolated. They had misdiagnoses. Some of the older families, the girls got Rett syndrome diagnoses, just other things. And they always knew they didn't really fit, that there was something different. So I think the testing is important for pitching to a community, and also for understanding if there are any specific medical or psychiatric issues that you want to be aware of.
Great. So I think I've covered just about all the questions in the chat. Does anyone have anything else? You're welcome to unmute and ask directly. I'm not seeing
I've gifted you a little extra lunchtime maybe today.
So you said that you would be interested in providing some training. Are there any other places that providers can get trained that you know of?
Specific to Phelan-McDermid syndrome?
Yes.
No, we're it.
Okay.
Yeah.
Do you know the story of how it became one of the few like autism, Down syndrome in chapter 393? Because it's so small, it's like there's other diseases that would fit, but somehow you guys got in the statute so you could be on the Medicaid waiver. I'm assuming there's a story there.
We're pretty proud of that. So our founder, Sue Lomas, who lives here in Sarasota as well, was when she moved here, she had her child, is now actually today, he's celebrating his 30th birthday. And so when he was transitioning from school care to adult care, she started to explore what the options were and the wait list and all the other pieces that go on with APD. And she actually got to know some people at APD and is a really strong advocate and convinced them to add the condition to the list. So with some backing from Dr. Phelan. So Katie Phelan is one of the geneticists that discovered the condition. And she actually lives in Fort Myers and is still very active with the foundation. So she was able to help show why there was a need for support services and helped get us on that list.
Well, that's pretty impressive because others have tried, even very small ones, the big ones. And even though you think it makes sense, so that's pretty impressive. The other thing I just want to mention is because you're in Chapter 393 and you're on the Medicaid waiver, the ARC of Florida is advocating for your issues to get better services in the community, to increase rates so there's more providers out there and they can grow and do more quality, but also to get people off the wait list. So you do have a partner.
That's great to know. Thank you. We could use partners.
Okay, so I don't see any more questions in the chat. Do we have any more comments for Ronni? Questions?
I'll tell you that there was 145 people on this call, on this presentation, and I know many more people will listen on YouTube because it's such a unique issue that people don't talk about a lot. So from behalf of the ARC of Florida, we appreciate you doing this for us. So that was really good that you were able to educate so many people.
Yes, it's great. Thank you all for spending your time with me.
All right. Well, we appreciate it so much, Ronni. Thank you.
Great. Enjoy your day, everybody, and thank you. Feel free to reach out. My email is Ronni, RONNI, @ PMSF.org.
And I will include that in the email that we send out as well.
Thank you so much. Thank you for the invitation, and I hope you will enjoy your day.
Thank you.
Have a great week.
You too.